Hello once again, ladies and gentlemen. Our topic in this discussion is going to be chorioamnionitis, and this is one of the more serious causes of maternal fever. It's also a big complication of premature and prolonged rupture of membranes. And so it's very difficult to talk about chorioamnionitis or talk about premature or prolonged rupture of membranes without talking about the other. So I suggest that you watch my topic on prom before watching this because that one's a little bit longer and gives you a better background on what prom is, and I'm going to assume that you have some working knowledge of that before we talk about chorioamnionitis. Just a reminder, if you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click on the link below in the description of the video or on the I button on the upper right-hand corner of the video. And if you could just consider chipping in $1 a month, a little bit goes a long ways to help keep these videos free. Thank you very much in advance. So these are some of the infectious disorders that are associated with pregnancy. As you can see, chorioamnionitis fits into the infection specific to pregnancy, and that would make sense because chorioamnionitis is an inflammation of the membranes, and those membranes do not exist outside of pregnancy. So this is an infection specific to pregnancy. I bold-faced the ones that I think are more important for the purpose of the USMLE. Chorioamnionitis will come up on the USMLE from time to time, but you won't need to know in too great of detail outside of the fact that it's a complication of prolonged rupture of membranes, of premature rupture of membranes, and that it's a cause of maternal fever. So anytime you have a patient with prolonged rupture of membranes who develops a fever, you should be thinking chorioamnionitis. We are going to also be talking about the diagnosis and treatment, but those are the basics that you'll definitely want to know for the USMLE. So some rudimentary anatomy here. As you know, here we have the fetus and the placenta here in a superior position, fundal position, which is exactly where we would want it to be. We don't want it down here by the cervix. And then there's these two layers that go around, kind of circumscribe the amniotic sac, and that's the amniotic fluid, and that's the chorion and the amnion. Together they make up what's known as the amniotic sac, which holds in the amniotic fluid, and that amniotic fluid is sort of a medium for the fetus to exist in. It also provides some cushioning for the fetus and helps it develop. As you know, when you have a oligohydramnios, you can have problems with anatomic development because the fetus is compressed. So the chorion is out here, and this is the outer layer of the amniotic sac. It's the outermost fetal membrane. It actually consists of two layers, an outer layer that's formed by trophoblast and an inner layer that is formed by mesoderm, the somatic mesoderm. It's actually from the outer layer that the chorionic villi protrude and go into the endometrium, and it's there that you have all that surface area for oxygen and waste transport. The inner layer of the chorion is in contact with the amnion, and the amnion is the inner fetal membrane, and that is composed of ectoderm and mesoderm. All right. So chorioamnionitis is caused from an ascending bacterial infection, which usually comes from the vagina. It can also come from the rectum, which then comes up through the vagina and then into the through the cervix and up into the membranes. And it infects the membranes which surround the fetus, the chorion and the amnion, and that can extend into the amniotic fluid and actually infect the amniotic fluid. And at that point, you can imagine you'd have a big problem on hand because now you have the fetus exposed to bacteria. Fetus does not have a developed immune system, and you can develop what's called FIRS, F-I-R-S, which we'll talk about in a little bit. Typically, the infection of chorioamnionitis is polymicrobial. So it used to be that group B strep was the #1 cause or the #1 isolate of chorioamnionitis. When there was chorioamnionitis and you got a sample of the amniotic fluid and you got a culture, it was usually polymicrobial, but it was group B strep that was the most common isolate. That is actually not the case anymore, and it's probably because now intrapartumly we treat for group B strep if it's present, but we can't treat for all the other things. And what do we use to treat group B strep? We use penicillin, and penicillin doesn't cover, it doesn't have a very wide range of coverage, at least. You're not going to knock out the gram-negatives and stuff like that. And so it actually happens that now gram-negatives are more common isolates. If you have to put into percentage terms, the most common isolates that we find in all the cases of chorioamnionitis actually is gram-negatives. In particular, E. coli, ureaplasma ureolyticum, and mycoplasma hominis. The infection may affect intact or ruptured membranes, and this is where some confusion can come on. Okay, so you don't have to have rupture of membranes to develop chorioamnionitis. Rupture of membranes is definitely the big risk factor. I would even say the chief risk factor for chorioamnionitis. But you can actually have chorioamnionitis with intact rupture of membranes. And so we're working two ways here. You can get rupture of membranes and then have an infection, which then causes chorioamnionitis. That's one of the more common ways that it can happen. And that's why prolonged rupture of membranes is associated with chorioamnionitis. Or you can have an ascending infection, which then invades the membranes, and actually because of that inflammatory response, it causes a secretion of prostaglandins and other inflammatory mediators, and that can actually weaken the membranes, it can ripen the cervix, and that can cause preterm labor. Okay, so you can work either way. So the risk factors for chorioamnionitis, as mentioned, prolonged rupture of membranes. If on the USMLE you get a chorioamnionitis question, the vignette will give you prolonged rupture of membranes, 19-20 hours since rupture of membranes, still no delivery, and now mom has a fever coming on, she's got some uterine tenderness. Maybe you get CBC and you find a high white count, or you look on the cardiotachometry and you see that baby is running a baseline heart rate of 180, something along those lines. Prolonged labor, kind of along the same lines. Preterm premature rupture of membranes and prematurity. Multiple digital exams with membrane rupture, so that's very important when you're doing digital exams, especially if the membranes are ruptured. You want to make sure that you're using sterile gloves. And it's not worth it to do digital exams more than once an hour. Group B strep positive. Group B strep can certainly ascend the cervix and invade the membranes. Epidural anesthesia, that's controversial. Cervical insufficiency, simply because there's less space between the vagina and the membranes. Alcohol and tobacco use, and nulliparity. The ones I would remember for sure are prolonged rupture of membranes, group B strep positive, and the multiple digital exams maybe, because that's kind of an iatrogenic cause of chorioamnionitis. So chorioamnionitis, one of the big problems from this is that it can lead to some really severe fetal complications. And those fetal complications can extend from the actual infection itself, which is acquired during delivery, or it can happen because of the inflammatory response, which can affect the fetus in utero. The big thing that can come out of it is cerebral palsy. And cerebral palsy is a lifelong disease process, and it is due to decompensation of the brain tissue. Okay, so this is a big one. So one of the big complications of chorioamnionitis is that the baby can get cerebral palsy. Another thing that we see with chorioamnionitis is an increased risk of early onset neonatal sepsis. So sepsis within the first few days to week of life. And so some of the things that you'll see with this are hemodynamic instability, temperature instability, you can get meningitis, you can get pneumonia. So look for that, and this is one of the reasons why it's very important that when you diagnose the mother with chorioamnionitis that you communicate that to the pediatrician who's going to be taking care of the baby, because in the nursery they're going to want to keep an eye out for any kind of sequelae that may be consistent with sepsis, because as you may know, if you know your pediatrics, neonatal sepsis can be kind of tricky to diagnose. It's certainly not like when it's an adult, it's a little bit easier. Okay, so they'll want to be aware of the fact that this baby was born to a mother with chorioamnionitis, so that if they see anything suspicious, they should get a blood culture and get some labs that may point to early onset neonatal sepsis. Okay, so this is just an idea of what's kind of going on here. Look on the right here. This is a normal placenta. Note that the membranes are clear, translucent. You can see all these veins and arteries here. If you look at this placenta with acute chorioamnionitis, you can see that the membranes are more hazy. There's definitely some inflammation going on here, and that's actually, well, it's sort of up here and down here. You can see it's a little bit more a little bit less here, but this is how you're going to, this is one way you'd be able to diagnose chorioamnionitis postpartum. But this doesn't really help us as far as preventing some of the complications, which, as we're going to talk about, one of the treatments is to prevent the complications by giving intrapartum antibiotics. And obviously this is not going to help you know to do that, because we're not going to be able to see the placenta until after delivery. So this is kind of the pathologic process that's going on. Chorioamnionitis and phenycitis. Phenycitis is a similar process, but it affects the umbilical cord. It causes maternal inflammation and also fetal inflammation, and this is just systemic inflammation. Fetal inflammation, also known as FIRS, which is the fetal inflammatory response syndrome, and this is just the fetal equivalent of SIRS. And this is caused by the release of prostaglandins and pro-inflammatory cytokines and chemokines, which can lead to damage to some of the end organs and to especially the lungs and the brain and central nervous system. So this can lead to fetal damage. With the mother, it can cause issues with her genital tract, and that can lead to preterm labor, especially if there's those cervical changes, which, as you know, prostaglandins are going to induce cervical changes. It can lead to preterm premature rupture of membranes, and that can lead to preterm delivery. As you also know, though, premature rupture of membranes is associated with prolonged rupture of membranes, which can then cause chorioamnionitis. So it works both ways. All of this, especially when you combine the FIRS along with preterm delivery, those are both risk factors for cerebral palsy. And so that's the one big sort of end complication that we're worried about here for the fetus. So the symptoms of chorioamnionitis, there are 6 major symptoms. You'll want to definitely remember 3 of them and then have in mind these other 3. So the big one that you need to know is maternal fever. Okay, there's a lot of things that can cause maternal fever. It doesn't even necessarily have to be an infection. But the thing that you need to know is that chorioamnionitis is always going to be associated with maternal fever for our purposes. Okay, so mom has a fever. Typically, with the fever, there's going to be tachycardia, but we are concerned with significant maternal tachycardia. Okay, that is a sign of some kind of an infection. And then fetal tachycardia, more than 160 to 180. The higher it is, the more sensitive it is for infection. Okay, so maternal fever and maternal and fetal tachycardia. If you put all 3 of those together, it has actually about a 90% sensitivity for chorioamnionitis. Some other ones are uterine tenderness, purulent or foul-smelling amniotic fluid or discharge, and maternal leukocytosis. Now, one of the problems with maternal leukocytosis is that there are a lot of things that can cause that. Steroids can cause that. Just the state of being in labor can actually cause leukocytosis. So if you get a CBC, if you're suspecting chorioamnionitis and you get a CBC, and it shows a real significant leukocytosis, That's consistent with chorioamnionitis. Another good thing to look for is that band count. If the band count is high, that's also more suspicious for chorioamnionitis rather than just steroids or labor. One of the major differentials is epidural-associated fever. So if you talk to the anesthesiologist, they'll know all about this, but you give an epidural and you can get a fever just from that. So that's one of sort of the quandaries of making this diagnosis. If the woman's already gotten an epidural and now she develops a fever and tachycardia, it can be challenging to make the differential. And I would err on the side of giving antibiotics just because you don't know. If you don't know, you should err on the side of caution. But you can always consult maternal fetal medicine, sort of send that off to them. Certainly on the USMLE, you're not going to be asked to differentiate between the two because it's very difficult. But it is good to know that it is one of our differentials. Also consider extrauterine infections that can cause fever and abdominal pain. So that would be things like urinary tract infection, appendicitis, influenza, pneumonia. So urinary tract infection, you can always just get a urinalysis. So that's one good thing you can do if she's got fever and abdominal pain. Get a urinalysis. If you see nitrites and esterase positive white cells in the urine, that is consistent with a UTI. Appendicitis, typically in right upper quadrant, but that can shift around during pregnancy. Influenza and pneumonia. So you can also consider even getting a chest x-ray. Not a big deal to get a chest x-ray during pregnancy. The radiologist technician will make sure and cover the uterus and the pelvic area up. So diagnosis is typically made clinically, and this is usually based on the presence of fever along with 2 additional signs. So fetal tachycardia, maternal tachycardia, or the presence of uterine tenderness, or the presence of foul-smelling exudate. The presence of risk factors, particularly if there's prolonged rupture of membranes, strengthens the diagnostic confidence. Now, traditionally, the gold standard for diagnosing chorioamnionitis is to get an amniocentesis and get an analysis of the amniotic fluid. That is the gold standard for diagnosis. But the problem with it is the best thing we can look at in the amniotic fluid is a culture. That's going to tell us for sure if there's infection of the amniotic fluid. But it takes about 3 days for cultures to come back. So that kind of makes it a little bit more difficult to use amniotic fluid to make an immediate diagnosis of chorioamnionitis. Nonetheless, there are other things that you can look at with amniotic fluid. You can look at the glucose, which is going to be low, the white count, which is going to be high, the protein count, which will be high, and I think it's matrix metalloproteinase, which is one of the proteins, the enzymes that they're looking for. Gram stain would be positive. And what does that look like? What does that profile look like as far as amniotic fluid being infected? What else do we see with this kind of profile that we see fluid-wise that indicates infection? The meninges, right? So when you're diagnosing meningitis by getting a spinal tap, that's pretty much what the CSF looks like. Okay, low glucose, high white count, etc. Another thing that you might want to just put in your back pocket, especially if you're M3, M4 medical student and you're rounding with a OBGYN, they may pimp you out on this and they'll be really impressed if you know this. Interleukin 6 is a marker for chorioamnionitis. We don't know how great it is, but there are studies out that are looking at chorioamnionitis and interleukin 6 and the relationship between the two of them. And obviously this is indicative of inflammation, but interleukin 6 is being investigated. We don't know exactly how sensitive and specific that is, but that's something that is sort of new. The management is to reduce maternal and fetal complications. That's the goal, especially neonatal sepsis, because the maternal complications are not quite as bad as the fetal complications. There certainly are maternal complications, and we're definitely worried about that, but the maternal complications are really not typically life-threatening, but the fetal complications most certainly are. And we will usually expedite delivery. We want to try to prolong it as much as we can, but it's sort of a balance between trying to prevent serious prematurity and getting that baby out, because this is going to typically necessitate, you want to get the baby out as soon as possible. So it's kind of, again, it's like a balance. You're always playing that balance game with trying to prevent serious prematurity, but also getting the baby out, because the longer the baby is in, the greater likelihood you're going to have that fetal inflammatory response syndrome. Okay, so fetal monitoring is important. Certainly if you have any kind of fetal distress, you want to get that baby out immediately. But the important thing you'll want to remember is the antibiotics that we give. Okay, so the antibiotics is ampicillin and gentamicin. Those are the two that we always give for chorioamnionitis. Now, there's other regimens that may be used, but this is the most common regimen, ampicillin and gentamicin. I'm not sure if you can use erythromycin. Remember back to prom, ampicillin and erythromycin is one of the regimens of antibiotics that you can give for prom, for latency and PPROM. But ampicillin and gentamicin are typically given for chorioamnionitis. Now, the way you dose gentamicin is going to be really important. You won't get tested on this on the USMLE, but I will just note it. Remember, one of the reasons why we don't give gentamicin in pregnancy is because of the possibility of sensory neural hearing loss. We can typically do this in late pregnancy if there's chorioamnionitis. We've decided that the benefits outweigh the risks. However, what you're going to do is you're going to dose this 3 times a day. So you'll give it IV 1.5 milligrams per kilogram every 8 hours. And the idea behind that, instead of giving it once a day, is that it will keep the peak levels down. So it will reduce the risk, slightly reduce the risk of that sensory neural hearing loss. Okay, ampicillin and gentamicin. You may add clindamycin, and clindamycin gives you good anaerobe coverage. You have to add clindamycin if you're going to be doing a C-section. Okay, so ampicillin, gentamicin, plus or minus clindamycin, but always add clindamycin if you're doing a C-section. Okay, if you want to write down the dosages, I'll give you the dosages. Ampicillin, you're going to be giving 2 grams IV every 6 hours. Gentamicin, 1.5 milligrams per kilogram IV every 8 hours. And clindamycin, you would give 900 milligrams IV every 8 hours. And these are going to be given until delivery. And usually you'll give, a lot of OBs will give a postpartum dosage for mom to reduce the risk of endomyometritis. But I didn't read anything on that in specific as far as what dosage and what's best to give. I will look that up. I will do a talk on endometritis later on. Antipyretics, acetaminophen is useful to give mom during labor and delivery. The reason that this is useful is it reduces maternal fever, and that's also going to be good as far as inflammation for the fetus and also reducing the fetal heart rate. For some reason, we know that reducing the fetal heart rate, getting the fetus out of tachycardia, is actually associated with a reduced risk of neonatal encephalitis. And so this could possibly reduce the risk of intraventricular hemorrhage, of cerebral palsy, and so definitely reduce mom's fever during chorioamnionitis if she has it. Okay, we want to try to get her afebrile, and so acetaminophen is really good for that. And then, like I said before, notify pediatrics. Make sure that the pediatrician is well aware in advance that this is a baby with chorioamnionitis. Okay, so IV antibiotics, antipyretics. Those are the two I want you to remember for the test. So, complications. There's always going to be complications on both the maternal and fetal end, so you'll want to remember these. First, on the maternal end, we know that there is an increased risk of C-section. One of the major indications for C-section is fetal distress. Now, what we have found is that by giving antipyretics, there's actually a reduction in the performance of C-sections, and that may be for 2 reasons. One, by giving the antipyretics, you're reducing the fetal heart rate, and the OB is going to see the fetal heart tracing and be a little bit more reassured. by it because you don't have as much fetal tachycardia. On the other hand, it may actually help the fetus by reducing the heart rate. That may have a benefit to the fetus and actually reduce true fetal distress. Because remember, just because you see a non-reassuring strip does not mean that the fetus is in distress, but it is non-reassuring for fetal well-being. Okay, so that's a good reason to be giving antipyretics when mom has a fever, especially in the presence of chorioamnionitis. Endometritis, simply because there's an infection in her uterus. Postpartum, she can develop uterine tenderness, fever. That is consistent with endometritis. You want to treat that with antibiotics. Wound infection, pelvic abscess, bacteremia, and postpartum hemorrhage, so probably a good idea to have Pitocin on hand to give to her after delivery. Fetal complications include FIRS, the fetal inflammatory response syndrome, which can lead to chronic lung disease, multi-organ damage, as well as brain damage. Perinatal death is another unfortunate complication of FIRS, or end result at least. Death isn't usually a complication, it's kind of an unfortunate result. Neonatal infection and sepsis, of course, for reasons we talked about. Respiratory distress due to pneumonia. Why do you get pneumonia? Because there's some degree of aspiration of the amniotic fluid, and when you have infected amniotic fluid, it's very easy then to get infection of your lungs. So look for pneumonia, especially when you have a newborn baby who is born to a mom with chorioamnionitis who develops respiratory distress. Obviously, the lungs are going to be the first place you look, and there's a logical reason for having pneumonia in this case. Cerebral palsy and intraventricular hemorrhage, and that's simply because of damage to the brain tissue. So to recap, chorioamnionitis is most commonly caused by an ascending infection, polymicrobial infection from the vagina and distal colon, which involves fetal membranes and occasionally the amniotic fluid. Prolonged rupture of membranes is a major risk factor, so rupture of membranes lasting longer than 18 hours from rupture to delivery. The most common symptom is maternal fever, unfortunately very nonspecific. But if you have that with maternal and fetal tachycardia, the sensitivity is about 90%. Uterine tenderness and purulent discharge are other symptoms. Diagnosis is usually made clinically, but amniotic fluid analysis and culture is the gold standard. Treatment is intrapartum IV antibiotics, ampicillin and gentamicin. You always give. You may add clindamycin onto that. You must add clindamycin if you're doing a C-section. Antipyretics for fetal benefit and expeditious delivery. Major complications are postpartum maternal infection, preterm delivery, neonatal sepsis and distress, and cerebral palsy. I will just add, I just remembered I did not put this in, but another complication down the road, and this is possibly because these babies are premature, but we got more studies coming out now that show that chorioamnionitis is an independent risk factor for necrotizing enterocolitis, which is a very serious disease of the young infant. And so look out for that. Remember, necrotizing enterocolitis, typically those babies are premature, but if there was a history of chorioamnionitis, that is something to be concerned for later on, and so that's something to keep in mind. If you have any questions, write me a note below. Otherwise, I will see you later.